And finally, the diverticular diseases, the important topic, Meckel's diverticulum. I hope you all have prepared extensively for exams. Meckel's diverticulum, very important question, isn't it? Yes, no? Is it important for our exams or not?
Yes, sir.
Even theory exams also? Yes, no? Okay. So
silence speaks, sir.
Sorry?
Yes,
All
sir.
gone, sir.
All gone. Okay, again we'll recollect it, no problem. So diverticular diseases. Diverticulum is just, this is the bowel, a small outpouching, that is diverticulum. So congenital and acquired, two types are there. One is congenital, one is acquired. Congenital is the most common. What is this congenital diverticulum? Meckel's. Example of congenital diverticulum is Meckel's. It is a true diverticulum. It arises on the anti-mesenteric border. Treatment is resection. So I'll explain these two. What is true diverticulum and what is anti-mesenteric border? What is true diverticulum? I mean by true diverticulum is
It didn't happen just by an outward, because of some other reason. It happened congenitally.
Okay. No, true diverticulum means it is having all the layers. This diverticulum is having all the layers of the bowel. Okay. Complete outpouching. Suppose this is the bowel loop. If small outpouching is there, it has complete outpouching. Everything will be in the diverticulum. That is true diverticulum. Whereas acquired diverticulums are false diverticulum. They don't have the complete coverings. Okay. Only the mucosa will be pouching, or only the serosa will be pouching, only the muscle will be pouching. That's all. So that is false diverticulum. So remember, Meckel's diverticulum is a true diverticulum and it arises on the anti-mesenteric border. See, suppose this is the large bowel. It is the one side it is attached to the mesentery. This is the mesentery. So it arises only on the anti-mesenteric border. Okay. Yes, no.
So complete outpouching of only all layers, sir?
All layers. Yeah, it is true diverticulum means all layers of the intestine, all layers of that part are outpouched. Okay.
Okay, sir.
So then only we call it as a true diverticulum. Okay, so this is congenital Meckel's diverticulum, true diverticulum, anti-mesenteric border. Whereas acquired
all
condition,
layers of large intestine, which is anti-mesenteric.
yeah, all layers of large intestine are outpouched. Okay. Sorry, all layers of the bowel, where it is coming from. Most of the times it is in 2 feet from the ileocecal junction. It is arises from ileum most of the times. Okay. So whatever bowl it is, most of the times it will outpouch. All the layers will outpouch. Okay. That is what I wanted to tell you.
Okay, sir.
Yeah. And see here, acquired, it is most common in sigmoid colon. Acquired. This is false diverticulum because it doesn't have all the layers. It doesn't have all the layers of colon here. It arises from the mesenteric border. So what is this mesenteric border? Mesenteric border is towards here. See, this is the anti-mesenteric border. This is the mesenteric border. Okay. Yes, no?
Yes, sir.
Yeah. This is an example. See here, this is the Meckel's diverticulum. So it is embryology. It is
so the diverticulum slide 1 second, please. Before this. Yes, please. Thank you, Dan.
Okay. So it is a embryological malformation. It is due to persistent proximal vitello-intestinal duct. This duct should disappear. But if it persists, this is persistent proximal vitello-intestinal duct. There is a rule of 2 for it. What is this? Most of the time it is present in 2% of the population out of 100. Suppose we are 100 people, every 2 out of 100, 2 people will have Meckel's diverticulum and no symptoms most of the times. And it is of 2 inches in length. 2 inches in length, that is 5 centimeters, and it is 2 feet from IC junction. IC is ileocecal junction. Okay, it lies 2 feet from the ileocecal junction. So suppose this is the small bowel, this is the colon, this is the IC junction. It lies approximately 2 feet, okay, from the IC junction. So this is the rule of 2. 2% population, 2 inches and 2 feet from the IC junction. Okay. Yes.
Yes, sir.
Yes, sir.
Yeah. This is all are important MCQs.
VID is what, sir?
Sorry?
Persistent proximal.
Vitellointestinal.
Vitello-intestinal duct. Vitello-intestinal duct. Okay. And there will be presence of ectopic mucosa. See, normally this is in the ileum, so they should have a ileal mucosa. But ectopic mucosa, like gastric mucosa, is present. Pancreatic mucosa is present. Okay. This is the peculiarity of this one: gastric mucosa and pancreatic mucosa. In children, most often we'll see. Okay. So, clinical features. How will the children present? The children will present with bleeding. They will have bleeding. Why bleeding? It is same as ileum, right? I told you all the layers of ileum are there. So why should it bleed separately?
So it's probably because ectopic mucosa
Very good. Yes.
contains the acid. It's a gastric substance, produces acid, forming of ulcer.
Yeah, because it contains ectopic gastric mucosa, it is a odd man out. Surrounding all ileum is there. Here, gastric mucosa is there. So this gastric mucosa is more prone to bleed. So in children, the most common clinical feature with which the present will present. These are all important MCQs. Remember. So in children, Meckel's diverticulum, it presents with bleeding. 1. So what is the investigation of choice? It is bleeding. Okay, it is bleeding. Small bowel bleeding. We had a lot of difficulty to identify where it is bleeding from. Yes, no.
Yes, sir.
So we will do a technetium scan. It is not CT scan. It is TC scan only. Technetium scan. That is tagged RBC scan. We give a technetium RBC and we can identify that point is bleeding. Technetium scan. Second point. And third point, suppose here is the Meckel's diverticulum here. So we can resect it like this actually, but there is chance that ectopic mucosa may be here. So what we do is we do a resection, complete resection and anastomosis. The other parts we will anastomose, resection anastomosis. So there is no chance of resection, wedge resection in a case of children. In children, you have to always do a resection anastomosis. Okay. Are these 3 points clear? Children, bleeding most common. Investigation of choice is technetium scan. Treatment is resection and anastomosis. Whereas in adults, obstruction. There is no ectopic mucosa once they grow adult. Okay, so it is obstruction is the most common feature. That bowel, that diverticulum may get stuck, obstruction. And investigation of choice is enteroclysis. Enteroclysis is nothing but it is a barium follow through. We call it as. We will take barium and we will take serial X-rays. Barium only. And wedge resection we can do here. What is wedge resection? So this you can just remove this part only. No need to remove the entire part because there is no ectopic mucosa. Yes. What are the complications? There may be bleeding, there may be obstruction, there may be hernia. This Meckel's diverticulum may go into hernia. There may be development of carcinoid tumor and diverticulosis. Can you name what is this hernia known as? Starts with L.
Little's hernia.
Very good. It is Little's hernia. Little's hernia, Meckel's diverticulum will be present inside it. Okay, good. Duodenal diverticulum, jejunal diverticulum, sigmoid colon diverticulum. Yeah, all those are not important, and sigmoid colon diverticulum is important. Sigmoid colon diverticulum, is it true or false? First one, is it a mesenteric border or anti-mesenteric border? True or false? Sorry?
False. False.
It is a false diverticulum. Is mesenteric or anti-mesenteric?
Mesenteric.
It is in the mesenteric border. Okay. So these two, this is a acquired diverticulum. It is not a congenital diverticulum. It is an acquired diverticulum. Okay. Whereas Meckel's is a
true one.
It's true and it's
Congenital.
anti-mesenteric border.
It is a congenital. It is true. It is on the anti-mesenteric border. Yes, you got it now. Okay. These 3 points are different for those sigmoid colon diverticulum and Macros diverticulum. So investigation of choice is barium enema. You give barium enema. It is sigmoid colon. Just give barium enema. You have this sawtooth appearance. Sawtooth appearance. Okay, sawtooth appearance. And the complication is it can infect and form diverticulitis. If it is infected, diverticulitis is there, then the investigation of choice is CECT abdomen. If only diverticulum is there, barium enema is okay. If diverticulitis infection is there, then CECT abdomen is the investigation of choice. This question, personally, I can't forget this question because when I was writing my PG entrance, this question was asked and I marked wrong for this. On seeing that diverticulitis, the investigation of choice, first option was barium enema. Last option was CECT. I mistakenly wrote it as barium enema. Okay, but the answer is CECT. For diverticulum, it is barium enema. For diverticulitis, it is CT. So don't make that mistake. Got it? Yes, no?
Yes.
Yeah, got it.
Okay. This is the sawtooth appearance. Sawtooth appearance. This is not right. Abdominal TB. I'll skip this. This is a medicine topic. We'll go to. This is all not necessary. This is important. I'll come back again.